Thank you, Rajesh. And I'll just go briefly through the basic aspects of therapeutic keratoplasty in these infectious keratitis cases, and what should be our way to handle these cases. You have heard various speaker before; they would have covered most of the time the indications, decision making, surgical technique, and most importantly, the post-op management and outcome is very important in these cases with therapeutic grafts. All cases where Dr. Rajesh talked about, if things are not going appropriately in terms of management with the medical treatment, then you require a surgical intervention to be done, especially perforated corneal ulcer, non-healing corneal ulcer for a long, long time, or a neurotrophic keratitis. And if you look into a various institution where they have, number of surgeries, large number of surgeries, almost 30 to 40% cases will be therapeutic keratoplasties. Therefore, it is important for people who are working in a corneal field to understand and to learn the art of therapeutic keratoplasty, because this surgery may be more difficult, more challenging than the routine keratoplasty as such. So it has to be done more meticulously and more effectively for a patient's benefit. If you know number of cases requiring therapeutic keratoplasty, the largest will be a bacterial corneal ulcer, but you still have fungal, viral, acanthamoeba into that group. But more important one is a group of cases where you had a culture negativity. You see here culture negative cases 30 to 40% in our series. If you have a case where repeated cultures are negative, these are cases they are not going to respond to your medical treatment. Ultimately, they may require therapeutic keratoplasty as such. So I think this particular point or decision making is very important. Don't wait for a too long, where the ulcer become too large, reaches periphery, involves the limbus sclera, then your outcomes are very very poor. Some patient may have a very deep involvement and may go into endophthalmitis. So you have to make a decision early enough and counsel your patient, record the pre-op findings, continue treatment, and don't wait for good quality donor tissue. If you don't get any quality of tissue, will be useful for safeguarding the globe and improving the outcome for these patients. Idea here is to get rid of infection, save the integrity of globe, and make sure patient has, if you have a good outcome, patient may have a vision also. Therefore, as I told, timing of a surgery is very important. Early intervention before it goes to a difficult situation is going to help in these cases. So this is a video I have got it from Dr. Rajesh Sinha. This is a perforated corneal ulcer patient. You have to make a trephination very effectively because these are soft eyes, perforated eyes. So you need to have a sharp trephination. Make sure you have a peripheral groove. Involve the entire area of infection and go beyond that. At least 1 millimeter beyond the infected area has to be taken care of. Make a light penetration. Don't damage the underlying structures. If needed, you can use a viscoelastic also. Make sure your trephination is such, which is around 70 to 80%. Never try to go full thickness in these cases. And subsequently, manage the entire graft in a way and remove the inflammatory markers. And sometimes you have a lot of membranes coming up, and that membrane should be gently separated. Even you may have a little bleeding coming up. Make sure you open the peripheral area by putting a little viscoelastic underneath the remaining host area. Then suturing has to be interrupted suture in these cases. You may do at least one or two peripheral iridectomy to safeguard the pupillary block happening in these patients, because there's a high chance you may have these also. So this is one case where you have done a graft. As I said, the area of infection should be taken care of. Go beyond the infection at least 1 millimeter all around. Once you have a graft in your hand, make a 3 sections, one for histopath, one for a bacterial, one for a fungal or other investigation which may require for these cases. So apart from the cultures, histopath is also important because that is going to enhance your outcome or a diagnosis of organism much better. This is one case. This is after almost 16 months. The therapeutic graft has acted like an optical graft because we did the surgery little early in these patients. You can see this is one patient where the infection is too large, and this is the graft which is post-op, and ultimately it will become hazy. So initiation is also very important, and this is superficial epithelial defect happening after a graft. Normally, therapeutic grafts are larger. The limbal stem cells may have got damage in these patients. Epithelialization is a problem. Always make sure epithelialization is done faster. Avoid toxic medications if possible, because antibacterial has to be given in these patients. This is a very, very large ulcer. This is what happens after 1 year. At least we have saved the globe from infection. This patient is suitable for optical graft now. Early intervention, good results. This is one more patient immediate after surgery. This is after 6 months. The results are pretty good in these cases. The important issue is to examine these patients subsequently also, because recurrence is very, very common in these patients. And that may be in the host graft junction area, near the suture area, or sometimes entire the graft can get infected. In a lamellar procedures, the interface infection is very, very important in these patients. If you have virulent organisms, more chances of recurrence happening. If you not appropriately remove the entire infected area, recurrence chances are much better in these cases. Laminar graft, Dr. Rajesh has covered beautifully. I'll just take out this particular area where you have a thin area, desmoter seal. You don't have to do a full thickness keratoplasty here. You can do a DALK and results are quite effectively good in these patients. In terms of post-op management, I think you should understand the bacterial keratitis. All cases you have to continue the antimicrobials, because that is classically recommended and should be done in these patients. What about steroids is another consideration which should also be looked into these patients. I would say as soon as possible you should start antimicrobials. Steroids, bacterial ulcer, you can start immediately within the first day also. Fungal keratitis, wait for at least 1 or 2 weeks till there's no recurrence, epithelialize, and you can start steroid if there's inflammation going on. Viral keratitis can be given safely. Acanthamoeba, again, you have to wait and watch. If too much inflammation, as Dr. Rajesh Sinha told us, you can start steroid there also. Cycloplegics, tear substitute, anti-glaucoma medication has to be given in all these patients. In terms of outcome-wise, we all know bacterial keratitis has a best outcome, then viral and fungal, because fungal will have a least outcome which is effective enough to decrease the recurrence wise, because recurrence chances are very high with the fungal corneal ulcers, and effectively the antifungal treatment has to go for a very, very long time. For acanthamoeba also, it may be 6 months to 1 year. Same thing holds for antifungals also. After the completion of your surgery, maybe antifungal goes for at least 4 to 6 weeks. This is one concept we have developed. If you cross-link your donor corneas, effectivity of this cornea may be much more. We found that the clarity of a tissue and the recurrence of infection was less if you use the cross-linked donor cornea for a therapeutic grafts, especially in fungal corneal ulcers. To summarize, we know that therapeutic keratoplasty is necessity in those cases where you could not manage with a medical treatment, or you feel that despite your medical treatment, the disease is progressing, and associated problems are also there where you think patient has a systemic immunocompromised situation where infection not going to handle. Then you must do a therapeutic graft in time. Don't wait for too long, otherwise your results are going to be poor. Antimicrobial treatment has to be given pre-op, pre-surgery and post-surgery also. In fungal corneal ulcer, wait for at least 2 weeks for starting steroid in these patients. Thank you for your kind listening.